So I'll talk a little bit about the Austrian experience, about PCR, Galactomannan, beta-D-glucan, lateral flow ICD, and BAL, and the kitchen sink, as we heard before. So when just looking on background, I mean, this is really nothing new for you. We have this crude mortality with invasive aspergillosis, and really the key factor is the early diagnosis, and then, of course, followed by prompt start of antifungal treatment, Aspergillus-specific antifungal treatment. But the problem we are having is that really invasive aspergillosis is not easy to diagnose. We have culture from BAL or even from some punctures or biopsies, but there we have mostly poor sensitivities below 50%. These sensitivities may be even lower in patients that already receive anti-mold treatment or prophylaxis. Histology, obviously, is something we always aim to get, but it's hard sometimes, and it's sometimes impossible to get them from these very sick patients in the hematological setting with thrombopenia, etc. And in vivo diagnostics of obviously very important and most important, obviously, the chest CT, but also as recently shown, the CT angiography, where you see these vessel occlusion signs, maybe something we might use more often in the future to diagnose invasive aspergillosis in conjunction always with mycological evidence and there in specific biomarkers and obviously the patient himself or herself. So not only diagnosis is difficult, so when we look on the setting of hematology, also all these different kinds of antifungal treatments we're using is kind of difficult. So we have on the one hand prophylaxis, mold-active prophylaxis, or empirical therapy in those patients with fever and neutropenia who are not responding to antibiotics. And when we test biomarkers in these patients, is mostly for a breakthrough infection. So if these patients are on prophylaxis, mold-active, or empirical therapy with an echinocandin, it's mostly breakthrough. And then we have this preemptive approach where we really wait until there is some specific sign for a fungal infection. And there, if we continue to use biomarkers, it's mostly for therapy monitoring. So I'll just start with one ball. And just about to get a feeling, because obviously time to results, as we want to diagnose early, treat early is very important. So for which of these following tests do you usually get back the results within 1 to 3 days? So A is Aspergillus PCR from blood, B is Galactomannan from BAL or blood, C is Aspergillus PCR from BAL, D is PCR from blood and BAL, E is PCR from blood and Galactomannan, and F is all of them. All right, so Galactomannan seems to be, and I'm kind of, yeah, so at least it's 10% who get PCR results from blood and BAL, which is quite good. So it's the same in my setting, like Galactomannan we usually get on the next day because we do daily testing. We also get beta-D-glucan, which is very special, that's why I didn't include it there. But PCR usually, it's still a pity that we have to wait for results, usually more than 3 days to get them back. Oh. I just missed one of the answers. 47% get PCR back. That's actually great. So 47%, so it's even 58% of people who get it back within 3 days. So that's actually a good thing. And maybe that's also a reason why PCR is used more here in the UK than it's used in Austria, where we usually wait 3-4 days. So 3 days, we are happy if we get them in 3 days, mostly. So next ball. Does your center routinely screen patients who are on mold-active prophylaxis, so high-risk hematological malignancy patients, for example, undergoing stem cell transplantation or induction therapy, who receive already mold-active prophylaxis but don't have a specific sign for fungal infection, just routine screening? So A is we don't screen. The only screen I'm using is the one from my computer. B is we screen some of them. Or C, yes, we do, because some of our patients get prophylaxis, others don't, and it's very hard to implement it. Only some get screened and others not. Okay, so that's something I'm definitely very satisfied with. So I'll talk a little bit more about that. And I'll also talk a little bit about the kitchen sink when it comes to this topic. So Serum Galactomannan, you know, it has been established since a long time. Sensitivity, specificity is overall pretty much convincing, although they really vary from setting to setting. We have a number of reasons for false positive results, but these are not really uniquely applicable anymore. It's certain preparations of parenteral nutritions or some formulations of beta-lactam antibiotics that in some centers cause a lot of false positives, but overall the test is working pretty good. But the main question obviously is how good is serum galactomannan working in those patients that already receive antifungals? And if you see here, there is one older study that really found that sensitivities are decreasing. Then there's another smaller study that also found that it might be useful for diagnosing of breakthrough infection if you do it diagnostic-driven. And really clarity about how useful galactomannan is in those patients receiving antifungals, mold-active antifungals, came with the study from Rafa Duarte, I think, in CID, who clearly showed if you use it diagnostic-driven in patients on prophylaxis, so you suspect breakthrough invasive aspergillosis, then the positive predictive value is very high with 90%. On the other hand, if you just do untargeted screening of everybody, you have a very low positive predictive value of about 10–11%. So really, 90% of the positive tests are false positive then. So really, the way to go there is to use it diagnostic-driven. And that's just, I think it's not really that the galactomannan test is not working well. It's just a matter of the prevalence. And as you can see here, you see down there, oh no, I stopped it. Okay, back there. I don't have a, but on the red, on the bottom, in the red, you really see the hyperprevalence. And as soon as the prevalence goes down, just when assuming 80% sensitivity and specificity, also the PPV, the positive predictive value, obviously goes down. And in patients on prophylaxis, naturally, hopefully, the rate of IPA is lower than in those without. So we have low positive predictive values. How does it look with BAL galactomannan? Overall, when looking on the studies, this might be even more promising in terms of performance than serum galactomannan when believing this meta-analysis. But also there's like different studies that show really different performances, especially this one study from Switzerland by Folt and colleagues showed pretty not that convincing performances in patients with hematological malignancies. And again, we see here that many of these patients were on mold-active prophylaxis at the time of bronchoscopy. And obviously, there were also other factors that explain these different performances in different groups of patients. But I always think that mold-active prophylaxis, mold-active empirical therapy is really an important point for decreasing sensitivity of our diagnostics. So there have been two other studies that looked on influence of antifungals on BAL fluid galactomannan, and one found really that maybe a lower cutoff is more useful when using galactomannan testing in those who receive antifungal prophylaxis or mold-active antifungal prophylaxis or empirical therapy, where they said 0.5 might be more useful. This is also something I believe. We did a retrospective analysis of our cases and really found that with a cutoff of 0.5, sensitivity without antifungals was really good with 95%, obviously. Sensitivity with antifungals was still tolerable with 71%, while when using the 1.0 cutoff, sensitivity decreased to 52% in those receiving mold-active antifungals. So overall, I'm also working a little bit in pulmonology, so I'm always really pressing to get some BAL and test some BAL, not only for galactomannan, obviously, it's also for PCR, and do other tests, and also culture, obviously, very important. So I always try, if it's somehow possible, to get some BAL. Sensitivity, of course, you have to know. You can't really rule out invasive aspergillosis in those who receive mold-active antifungals, but nevertheless, it's a useful and helpful test. What's very important from a laboratory point of view is that really sometimes when the BAL fluid is not really fluid in the lab, they use some substances such as diotrietol, the sputasol, or other substances that liquefy the BAL, and really these substances bring the galactomannan level to 0. So that has been shown by our group for sputasol and very recently also by Catherine Lagrou's group for another liquefying agent. So really don't test BAL for galactomannan once you have pre-treated it with some liquefying agent. How about neutropenia and influence on galactomannan? Here we really see that there seems to be a bigger influence. Of course, invasive aspergillosis looks different in those who are neutropenic, also in terms of radiological appearance. And there seems to be therefore also a bigger influence of neutropenia on serum levels than on BAL levels, here shown in an animal study, but later on also shown retrospectively by Cordonnier and colleagues, where we really see the better performance in terms of sensitivity with those with very low neutrophil counts, severe neutropenia, when compared to those with higher neutrophil counts. And this seems to be somehow specific to blood, whereas in BAL there seems to be not really an influence. So when should we test galactomannan and how often? I overall say in patients at lower risk for invasive pulmonary aspergillosis, I would really go for a diagnostic-driven approach, galactomannan testing in case of clinical suspicion, preferably always use BAL because these patients might be less neutropenic, and additionally serum GM you can do, but you have to be sure and just remind that the negative predictive value won't be too high, so a negative result does not rule out aspergillosis. In patients at high risk, that's really the question, do they receive anti-mold prophylaxis? And if there is mold-active prophylaxis, definitely go for a diagnostic-driven galactomannan testing approach, while when there is no mold-active prophylaxis, when you're using fluconazole or nothing, a galactomannan screening may be recommended in these high-risk patients. Treatment stratification, another interesting point, if you really want to see also from a laboratory point of view, we are all clinicians, so we see it also, and we have a CD, so there may be more important things to monitor, but it might be also useful to use it as a therapy monitoring tool if initial serum galactomannan is positive. How about CSF and urine? I think CSF, there is definitely future studies needed, but overall, when looking on this preliminary data, it's pretty much convincing that in those few cases where there is really CNS aspergillosis, galactomannan may work pretty good in CSF. Urine would be something which would be interesting, especially for settings outside the hospital or even for home testing in the future. And there we just had very recently a study where we obviously showed that in urine, the concentration of galactomannan really depends on the urine concentration, and we used urine creatinine to show that this is really depending, and we created or calculated a galactomannan creatinine ratio in urine samples where we saw that the performance was improved when calculating this ratio compared to just testing urine as it is for galactomannan. But overall, I still think there is like future studies needed before this can really be introduced into routine, but it's an interesting point also for point of care tests, obviously, in the future. So lateral flow device, I'll just talk very shortly about that. As you all know, here in the UK, it's a point of care test for invasive aspergillosis, and it detects active growth of aspergillus via this monoclonal antibody JF5. It's simple and rapid, and when looking on the studies, it really has promising performance in different groups of patients. The only thing is when you just look down in hematology, the sensitivity seems to be a little bit lower compared to the other patients. And again, here in this retrospective analysis, we clearly showed that the reason, again, is mold-active antifungal treatment, where sensitivity decreases to 52%, compared to 86%. So also on the lateral flow device test, mold-active treatment or prophylaxis seems to have an influence. So overall, when to use, I mean, of course, as soon as it is commercially available. I personally have only experience with using it in BAL, Luis, for example, I don't know if we'll talk about it. I'll show a little bit about his study. Also, he has experience in using it in serum samples with a very interesting objective approach, I would say. We just used it in BAL samples, and there it seems to be pretty promising, especially when combining it, as, for example, with Galactomannan or PCR. And of course, it's point of care, so it's something which we clinicians love. We can have it on the same day within an hour or so, and then start immediately with a targeted treatment. So how about Aspergillus-specific PCR in blood? I chose one study which is a little bit older because I'm sure Luis will show many of his newer studies, so I didn't want to interfere with that. So an older review from 2009, and overall sensitivity and specificity pretty good for 2 consecutive positive samples, 75% and 87%, which is pretty much convincing. When 1 sample is positive, the sensitivity even increases while the specificity naturally decreases, but Luis will talk much more about that, so I don't want to go too much into detail. But then there's one thing, and it's really like there's lots of studies in many countries, and it seems to perform pretty well. But we in Middle Europe, in many settings, we have the problem that it really did never work that well. Of course, there's different PCRs. We did often not use the standardized PCRs, but many of our colleagues have results of PCR screening in blood, which are really not that good, but have not been published because it's negative results. And one major thing why this is, or explanation, may be anti-mold prophylaxis. And what was really interesting in a recent study by Löffler and colleagues who tested samples from Innsbruck, and they really found that the specificity in those samples was really low, with 27% for 1 sample and 50% for 2 samples, but then also the sensitivity decreased. So in our settings, blood PCR really seems not to work that well. When just calculating, even for an IPA prevalence of 10%, this would mean a positive predictive value of 12%. If 1 sample is positive, or if 2 samples are positive, a positive predictive value of 9%. But overall, I think this fits very well to like our other results from blood. So overall, I can say also Galactomannan may be not working as well in blood in Middle Europe than it works in the UK, for example. So that's where I could put the kitchen sink. So if you have patients on mold-active antifungals, don't screen untargeted for PCR or Galactomannan. When looking on the sensitivities, it might still be useful in some patients where you suspect invasive pulmonary aspergillosis and can rule it out, but just untargeted screening, you will have a very low positive predictive value with blood PCR. Combination, that study I shortly talked about, where it really seems that a combination of PCR and LFD from blood here in the UK worked really good with very, very promising performances in this study by Luis. And for us, at least in Middle Europe, this would be the holy grail, Aspergillus PCR from BAL. The problem is, and Luis is working on it, which is really, really great and really, really important, is the lack of standardization. We have all these different PCR assays, but to have a standardized BAL Aspergillus PCR assay would really be of great help and something we very much look forward to in our setting. Combination, there's a few studies that also looked on combination of PCR and Galactomannan. Here is a study from Mannheim that found, depending on how you combine it, it's either both positive or either or positive. Very, very promising performances if you combine Galactomannan and PCR from BAL. And also in this small study, we found that combination with the lateral flow device test in BAL, PCR and the lateral flow device test may be very promising. So shortly, I'll also come to 1,3-beta-D-glucan. It's more a pan-fungal marker, not Aspergillus specific, which is a plus and a minus, obviously. What's very important, there are several commercial kits available. We usually all use the Cape Cod kit in Europe. And one possibility to use that kit is really to put this whole kit on the coagulation automat and to do BDG testing on the coagulation automat, which makes single sample testing possible in the laboratory and also makes the test much cheaper. And that's what we're using in Austria, in Graz. And obviously, same as for Galactomannan, there is a number of reasons for false positive results. Some of them we could confirm in recent studies, others not. So one definitely reason that is repeatedly observed is gram-negative bacteremia or bacteremia by enterococci. This was also seen in our samples we tested retrospectively. Moderate mucositis seems not to cause a false positive BDG result, whereas common immunoglobulin preparations usually themselves test positive, and also anti-infectives, as shown by Oliver Cornelli's group very recently, may test positive for beta-D-glucan. So that's always something you have to keep in mind. And Oliver Cornelli, I think very recently, I don't know if it's published yet, even showed that immunoglobulin after given to patients may cause a false positive beta-D-glucan test like until I think 36 hours after you have given this to the patient. So that's something you have to keep in mind. Overall, however, performance as a screening tool pretty much convincing when we believe these American studies with high positive and negative predictive values. And we just looked on it in terms of specificity, and I think really these results are really surprising in stem cell transplant recipients, where we really found that specificity was really high with 94 to 96%, much higher than we expected. So it was a highly specific test in these 352 samples from 60 patients. We could not really evaluate sensitivity in this study, though, because it was very few samples. What about beta-D-glucan and BAL? There is studies that keep on going. They keep coming. I think all these studies more or less show the same. There's really reduced specificity when compared to other bowel fluid markers, so not really useful to test BAL for beta-D-glucan. One explanation may be pneumocystis colonization, another obviously Candida colonization of the lung. And we recently showed that while Candida colonization really led to much higher beta-D-glucan levels in BAL, it might still have some benefit for mortality prediction in 252 patients, where we clearly see in these Kaplan-Meier curves that those with higher beta-D-glucan levels above 200 had a higher chance of dying within 2 days. And this was, much higher significant than Candida colonization itself. Urine, I think I go over that, also something which is very preliminary and may also very high levels in urine have some clinical impact, not just moderately elevated levels. So overall, beta-D-glucan definitely recommended for patients with suspected Candida pneumocystis infection. In molds, it's always the questions, what else you're using, what's the additional benefit? So that's what you have to decide from center to center. And on the correlation automat, you get results within 24 hours. And my last topic will really be Mannan, anti-Mannan, which has had like a review. I'll just go directly into it. In 2010, where there was a lot of studies summarized that showed pretty good performance for combining Mannan antibody and Mannan antigen and anti-Mannan antibody of 83% sensitivity and 86% specificity for candidiasis, and in particular hepatosplenic candidiasis. But I also have to say that since then, other studies came out that really showed that specificity in particular for the anti-Mannan antibody may be pretty low, just around 60%. And the same was also observed in our center. So really, Mannan antigen may be a useful test, I think, especially when you suspect Candida infection, invasive Candida infection. I'm not so sure about the anti-Mannan antibody because also sensitivity is not that high for this antibody and specificity is very low. So it may be something you may consider if you have suspicion of invasive Candida infection to test in addition. But obviously for Candida, there's lots of things coming out. I mean, this is very preliminary, but also warrants further investigation, interleukin 17A, which was very high in patients with candidemia versus those without, with a really nearly perfect area under the curve in this study. So it's definitely something to consider or test in future studies. And of course, T2 magnetic resonance for detection of Candida in blood culture. Very, very promising performance, and hopefully it will come also soon to Europe. And I think also other bigger studies are needed with more positive samples to confirm these results, but I think the future is really bright for Candida. So take-home message for Aspergillus is really a Galactomannan test, important tool for invasive pulmonary aspergillosis diagnosis, especially when you get results back within like a day maximum, as in our setting. BAL, always preferable to serum, but we're not always able to get BAL, but if we can, we should. Antifungal prophylaxis is always like an indicator for choosing more diagnostic-driven approach and not undirected screening. PCR from BAL, obviously something you always want to perform, Aspergillus-specific, but also to detect, for example, azole resistance, a very useful tool, Fungal, mucorales. So this is really the way to go. PCR from blood really depends on the setting. And lateral flow device test, once it is commercially available, maybe a useful adjunct tool where you really get results within a few minutes to an hour and can start immediately right away. Beta-D glucan in IPA really depends on the setting, what other tools you're using for screening, if you want to use that in addition. And culture, obviously, you need always. And I already talked about that, and with that, I want to thank you for your attention. Thank you.